This talk is about somatosensory evoked potentials, technical and anatomical issues. It is the third and the last talk about somatosensory evoked potential technical issues. This talk is intended for the Niklaus Children's Hospital Clinical Neurophysiology Fellows. It will be conducted in a question and answer format. The first question: reference value should be established for men and women separately. A true, B false. This general chart lists all the factors that can potentially influence somatosensory evoked potential latency, amplitude, and morphology. Gender is one of these factors. One author found women's central conduction to be 1 millisecond faster than men. Yet the majority of authors have found no difference between men and women if height and age is taken into consideration. So the answer to this question is B. Next question: sleep reduces the amplitude of cortical somatosensory evoked potentials. A true, B false. Among the factors that can potentially influence somatosensory evoked potential latency, amplitude, and morphology, cooperation is at the top of the list. This is an example of a somatosensory evoked potential study done in an unrelaxed anxious patient. Notice that all the tracing are very wavy. This is an example of a somatosensory evoked potential study done in a relaxed patient. The waviness is much less, as you can see. And this tracing was done with the patient asleep. Notice that the waviness is almost gone. The difference between an asleep and wary somatosensory evoked potential is significant. In the next frame, I will show you an example. This is a posterior tibial nerve somatosensory evoked potential recorded in one patient in both stages, sleep and anxious, one after the other. When the left side was being recorded, the patient was asleep. When the right leg was being recorded, the patient was anxious. When asleep, the left popliteal fossa potential latency was 5.6 milliseconds, whereas on the right, when awake and anxious, the latency to the popliteal fossa potential was 5.1 milliseconds. The difference is not significant. When asleep, the amplitude of the left popliteal point potential was 3 microvolts, and so was on the right, when the patient was awake and anxious. Notice the different amplitude scale used in these derivations. Latency to the lumbar point was 15.7 milliseconds on the left while asleep and 14.6 milliseconds on the right while awake and anxious. This is a difference of more than 1 centimeter, which is significant, but it does not warrant to label the study as pathological. Peak latency to P31 on the left while asleep was 23 milliseconds, and on the right while awake and anxious, it was 22.6 milliseconds. Again, not a significant difference, but a difference nevertheless. On the left, while asleep, the latency to P34 was 26.1 milliseconds. And on the right, while awake and anxious, the latency to N34 was 28 milliseconds. This is a significant, but again, not a pathological difference. But a point to be considered here is that the awake recording had a longer latency than the sleep recording. Now we can see that on the left while asleep, the latency to P37 is 30.4 milliseconds. And on the right, while the patient was awake and anxious, latency to P37 was 36 milliseconds. A latency of 36 milliseconds to P37 is a normal latency. But this is a significant finding based on two accounts. The first issue is that the awake potential latency is more prolonged than the sleep latency, and usually it is reported to be the other way around. And the second issue is that the difference between latencies is 5.6 milliseconds, which is definitely abnormal. The amplitude of the left P37 is 0.1 microvolts. The amplitude of the right posterior tibial nerve P37 is 0.23 microvolts. This is a significant asymmetry, which is over twice one from the other. It is also important to remember that although most authors do not use asymmetry as a criteria for abnormality, and they only use the absence, which is the absolute asymmetry, the degree of asymmetry present in this case raises the possibility of an abnormality. But most importantly, talking as a whole, it is important to take into account that the comparison between these two studies done in the same patient, one after the other, initially while asleep and the other one while awake and anxious, is certainly confusing. It is confusing because shifting longer latencies on one side or the other and the almost absence of cortical potential while asleep. The literature on the subject of the difference between a sleep and awake recording reflects this confusion. As a whole, the most consistent findings that I can encounter in my reading is that the latency to N20 and probably to P37 is minimally delayed during stage 2 sleep as compared to during wakefulness, a point that you can see clearly in this frame. Another consistent fact is that during awake, superimposed waves tend to be present in the rising stroke of N20 that are not present during sleep. Amplitude of cortical potentials also tend to go down during stage 2 sleep. The behavior of cortical potential during other stages of sleep is unknown, including during REM. Some studies in neonates and young children have mentioned that latencies to somatosensory potential during REM sleep and wakefulness are the same. In general, we can say that sleep tends to produce amplitude and increased latency of somatosensory evoked potentials recorded from the cortex. It is also a general feeling that there's a reduction in amplitude. This reduction in amplitude seems to be more consistent than the increase in latency. Another generality that we can make is that anxiety decreases the reliability of any somatosensory evoked potential study. My best advice on the subject is not to let the patient fall asleep while a somatosensory evoked potential study is being conducted, and to encourage relaxation, implying that we do not like to see the patient do hard math or any type of very strong strenuous thinking during the study, because more confusing patterns tend to appear. Now, in infants and young children, somatosensory evoked potential is often done when the patient is asleep or sedated. This fact should be taken into account at the time of generating normal controls for each lab. So the answer to this question is A. Next question. How many potentials have been consistently described in the regular upper extremity somatosensory evoked potential? A5, B8, C7, D12. In the past, when we have spoken about median nerve somatosensory evoked potential and as upper extremity evoked potential as a whole, we mentioned 5 clinically relevant potentials. The ERP point potential, N13, P14, N18, and N20. But as you can see in this figure, some authors label more than 5 potentials. So we need to know what that is all about. And the same here, you can see that the number of potential labeled are far more than 5. In this figure, I have placed big numbers corresponding to the clinical important potentials to which I have alluded before. The other potentials I have just labeled. As you can see, certain potentials have multiple names given to them with more or less good reasons, according to my humble opinion, by different authors. To make this figure more complex, I have added for certain potentials more than one origin, again following different authors' consideration. I hope that during the course of this talk, this figure will become more and more clear to you, that I am sure it looks at the moment. I will start by telling you about a potential called by 3 different names: P9, N9, and neck potential. This potential is generated at the axilla, and it creates a far field in the neck that extends to the scalp. These facts seem to be the only ones that all authors agree. I have represented this field, as you can see here, as a positive one, but according to some authors, this 3-name potential also has 3 humps, 2 positive peaks separated by 1 negative peak. At the level of the scalp, this potential presents as a positive potential when recorded from the contralateral scalp to the contralateral ear points. At the level of the neck, its interpretation is more confusing. It is recorded as a negative wave as indicated by the arrow when recorded using a derivation going from the neck to the forehead. This derivation is depicted in this frame by the green and the light gray ovals. Kimura, in his book, mentions the possibility that the ear point potential contributes to the negativity of this potential. Another early potential is N10. N10 corresponds to the electrical volley traveling through the brachial plexus proximal region, as I have shown in this frame. Another traveling potential not used clinically but often mentioned in the board examinations is N12. This potential is produced by the dorsal column volley as it goes through the foramen magnum. Cervical 13 is one of those potentials that, although most authors consider it to originate in one place, the dorsal horn of the cervical column, a few cast doubts on this site of origin. They consider that the site of origin of N13 is the cuneatus nucleus in the lower medulla. Yet, this view is not shared by many. All in all, there are a total of 12 potentials that we need to consider when talking about upper extremity somatosensory evoked potentials. So the answer to this question is D. Next question. Which of the following traveling potentials is recorded during regular somatosensory evoked potential study as a near field? A. Cervical N13, B. Air point potential, C. N12, D. PN9. The chart I have just introduced lists all the relevant median nerve somatosensory evoked potentials, the 12 of them, and their most important features. One way to start looking at this chart is to consider two types of potential, traveling and stationary. Among the traveling potentials we have the P-9 potential, to which we have alluded before as the potential with three names. This is the first potential usually captured in most non-experimental, carefully performed median nerve somatosensory evoked potential studies. This is so when using regular montage and amplification. Yet, if we use a special experimental methodology, earlier potentials N3, N9, and N6 can be seen to arise after the median nerve stimulation as the median nerve electrical activity reaches the brachioradialis muscle, the elbow, and the proximal arm respectively. The special methodology that would allow us to see those earlier potential consists of placing subcutaneous needles along the arm, represented in this frame by different color lines referred to close by electrodes, represented in this frame as gray ovals, and simultaneously recording from the neck to the contralateral hand and from the contralateral scalp to the contralateral hand. Take a few seconds to look at this frame to orient yourself regarding the montage being used. Although not shown in this figure, as electrical activity traveling the median nerve from the hand to the shoulder goes through the changes in direction following the anatomical course of the median nerve and the changes in volume, conduction, size, and medium in its course, the production of far fields take place. These far fields can be recorded at the neck and at the scalp as minor deviations. These far fields are recorded in addition to near fields recorded by bipolar recordings between the subcutaneous needle and the close placed reference electrodes. Going back to P-N9, we can say that this potential is a brief far field positive potential capture using scalp electrodes, and that it is generated, as we previously mentioned, by the traveling volley in the medial nerve as it enters the axilla. In this frame, I have introduced a photograph of a left arm to illustrate the origin of this potential, which I have done so by placing the starburst at the level of the axilla. P-9 is likely to be produced by the distortion of the quadrupole as it moves from the restricted confine of the arm to the trunk. It is at this time that the quadrupole produces a positive potential when the arm is abducted, but if the arm is adducted, it also creates a negative field produced by the asymmetrical quadrupole configuration. Two important points are probably explained by this occurrence. One is that the change in arm position produces a change in configuration of the potential, and the second is that we may find a biphasic configuration because of this double type of presentation. As previously mentioned, the production of P9-9 is just distal to the brachial plexus as it is presented in this figure. So P-N9 is a traveling field. Next, I will mention another traveling field, that is the air point potential. This potential originates at the level of the trunks in the brachial plexus. This potential was thoroughly addressed in a prior video titled Cutaneous Stimulation. The next traveling potential is N10, then N12, and then P14A and B potentials, and the last potential is P14C. One thing common to all traveling potentials is that they arise from myelinated axons at nerves or central nervous system white matter bundles. Most of the traveling fields are recorded using regular montage as far fields, except for the air point potential. This field is recorded with regular montage using clinical testing as a near field. In this frame, I have introduced two frequently used derivations to highlight the relation between P-N9 recorded from the contralateral scalp to the contralateral air point and the air point potential recorded from the ipsilateral air point to the contralateral air point. So the answer to this question is B. Next question. P14 is generated at the internal arcuate fibers and the median lemniscus. A true, B false. One of the traveling potential I just mentioned was P14A and B. This potential is believed to arise at the level of the lower pons as the internal arcuate fibers become the medial lemniscus. This potential is likely to be the consequence of a quadrupole distortion as the electrical field shifts direction from a horizontal orientation to a vertical orientation in the standing patient. Potential P14C also falls in the same category of controversial potentials. It is a white matter potential. It is a traveling potential, and it is a far field, just as P14AB was. But P14C appears to be generated higher up in the upper pons. So the answer to this question is A. Next question. An electrode placed in the anterior neck will capture cervical N13 as a positive potential. A true, B false. I am going back to the table that I showed you before to talk to you about stationary potentials. In this frame, you can see that I have highlighted cervical N13. Cervical N13 is the first stationary potential we encounter during regular median nerve somatosensory evoked potential studies. The dipole that creates cervical N13, I hope you remember from previous video in this series, has its negative pole directed towards the back of the neck and its positive pole anteriorly. This frame depicts two tracings. One collected by a posterior neck electrode in purple, and in yellow a tracing collected from the esophagus, both referred to a neutral electrode. As you can see, the purple tracing demonstrates a negative potential and the yellow a positive potential 13 seconds after the stimulus. Cervical N13 is listed in Levin and Luther's book as a near field. Cervical N13 has the same latency but different amplitudes at different levels of the cervical spine. The amplitude is maximal from C3 to C7. So the answer to this question is A. Next question. Which of the following potentials can be used to find the Rolandic fissure? A. N18, B. N22, C. N20, D. N30. The second stationary potential, usually captured in regular somatosensory evoked potential studies, is N18. It is currently considered by most authors to be a thalamic potential, but others believe it is generated at the tectal or pretectal region. N18 can be captured in isolation recording from the ipsilateral central region referred to a non-involved site, or in conjunction with N20 if recorded from the contralateral centroparietal region referred to a non-involved site. Next potential is N20. N20 is a stationary potential. It is the first cortical generated potential. It arises from the posterior central gyrus. It is considered to be generated at cortical area 3B and to result from a stimulus arising from the thalamic ventroposterolateral caudalis nucleus. This potential has a horizontal representation, creating a negative field over the posterior central gyrus rim and a positive field that projects to the anterior central sulcus. The direction of these fields are represented by the green segments of the wave from each of the three electrodes. I have changed the color of the lines representing the fields in this frame. The negative potential is now purple. The horizontal potential I have left green, and the positive potential is now magenta. I have done this to illustrate a point. The point is that the inversion of N20 at the central sulcus or Rolandic fissure, as you can see in these frames, allows to detect the Rolandic fissure. N20 can be isolated from N18 by recording from the contralateral centroparietal electrode referred to the opposite centroparietal region, or by referring it to the frontal region. Next cortical stationary potential is P22. This potential is only captured over the presental region. It is likely that it is generated in area 4 as the result of an inhibitory influence arising from the thalamus. It is interesting that this potential increases with age, often involving the hemisphere contralateral to where it is initially originated. Next potential is P27, which has been considered to be generated from cortical stimulation of area 1 by fibers arising from area 3B. P27 is mainly recorded from the posterocentral gyrus. The last cortical stationary potential that I would mention is N30. N30 is believed to arise from the premotor or supplementary frontal area. This potential, contrary to P22, decreases with age. So the answer to this question is C. Next question. Cortically generated N19 or N20 is consistently recordable at temperature above 26 degrees centigrade, disappearing between 20 and 25 degrees centigrades. N10, that is N9, and P14, that is P13, 14, will persist between 20 and 25 degrees centigrade. A true, B false. We are back to the general chart about factors that influence somatosensory evoked potentials to talk about temperature. I have reintroduced the table with the 12 potentials to point out some facts related to temperature. N10 is preserved even at temperatures between 20 and 25 degrees centigrade. And so is P14A and B and P14C. N20 disappears when temperature drops between 20 to 25 degrees centigrades. So the answer to this question is A. Next question. The amplitude of somatosensory evoked potential components have a poor correlation with temperature. N10 and P14 tend to initially increase, whereas N19 or N20 tends to decrease with declining temperature. A true, B false. N20 always drops in amplitude with declining temperature. Doesn't matter how little the decline is. N10, P14A and B, and P14C, that is the P14 complex, initially increases with declining temperature. So the answer to this question is true. Next question. Hypothermia produces increased latencies of peaks of N10, P14, and N19 components, but does not affect N10 to P14 nor P14 to N19 interpeak latencies. A true, B false. This is the only paper I could find which I thought that had some clear information regarding hypothermia and somatosensory evoked potentials. In it, you will find the following statements. Hypothermia produced increased latency of the peak of N10, P14, and N19 components. The prolongation was more severe for later components, so that N10 to P14 and P14 to N19 interpeak latencies were also prolonged. Another statement in this paper is that the rise time and the duration of N10, P14, and N19 increased progressively with cooling. So the answer to this question is B. Next question. How many potentials have been consistently described in regular lower extremity somatosensory evoked potentials? A3, B10, C7, D12. When we spoke of leg potentials, that is of leg somatosensory evoked potentials in a prior video, we mentioned three important potentials. The lumbar potential, N34, and P37. But as you can see in this frame, other authors have labeled more than three potentials. This is the flow chart of the lower extremity potentials. The chart follows the same principle as the one we just saw regarding the upper extremities. It starts with ankle stimulation of the posterior tibial nerve and ends with cortical activation. The major intermediate stations are basically the same in principle as those in the upper extremity. I will, at this point, talk a little bit about each of them. Mercifully, altogether, there are only 7 potentials that are usually talked about when we talk about lower extremity somatosensory evoked potentials. So the answer to this question is 7, C. Next question. The dorsal horn on the lumbar sacral eminence contributes to dash A, P18, B, N22, C, P31, D, P37. This table and its adjacent diagram will be used to talk about the lower extremity, fundamentally about posterior tibial nerve potentials. I will first mention the traveling potentials as I did when I talked about upper extremity potentials. The popliteal fossa potential is a near field traveling potential with the typical positive, negative, positive configuration corresponding to a moving quadrupole. P18 is also a traveling potential. In Kimura's book, it is labeled P17. Most authors I have read believe it arises from the proximal lumbar plexus prior to the fibers of this plexus entering the spinal canal through the intervertebral foramina. N24 results from the dorsal column volley going through the foramen magnum. And P31 is the last traveling potential usually recorded using regular lower extremity somatosensory evoked montage. It corresponds to the electrical activity traveling in the internal arcuate fibers as they go into the medial lemniscus. The first stationary potential in the lower extremities is N22. This is considered a stationary potential despite the fact that some authors, based on the possibility of the cauda equina contribution, consider it that it may have a traveling component. Next stationary potential is N34. Some authors believe it is primarily generated by the tectum, but others, we shall say the majority, believe that it originates in the thalamus. And the last clinically recordable potential in the lower extremity is P37. P37 arises from the mesial postcentral cortex. So the answer to this question is B. Next question. The temperature at the site of the stimulus should be 32 centigrades or higher in the upper and lower extremities. A true, B false. I introduce again the chart about the different factors that influence somatosensory evoked potentials. And I do so in order to talk about temperature. It is recommended that upper extremity temperature be kept at 32 degrees centigrade or higher at the time of the study, whereas lower limb temperature when conducting a lower extremity somatosensory evoked potential only have to reach 30 degrees centigrade or higher to be acceptable. So the answer to this question is false. Next question. Which of the following drugs prolong central interpeak latencies? A. Phenobarbital, B. Phenytoin, C. Diazepam, D. Carbamazepine. I introduce the general chart again. This time is to talk about the influence of drugs. And the one drug to remember in the list of drugs asked in this question is phenytoin. Phenytoin prolongs interpeak latencies. Other drugs have no effect. Diazepam is a muscle relaxant and often allows better visualization of the wave, but it does not alter interpeak latencies. So the answer to this question is B. Next question. Halothane, enflurane, and isoflurane, which are halogenated hydrocarbon inhalation agents at high concentration, will produce A. Increased cortical latencies, B. Reduced cortical potential amplitudes, C. Prolonged central conduction time, D. All of the above. The effect of anesthetic on somatosensory evoked potential has traditionally been discussed in relation to peripheral waves, subcortical waves, and cortical waves. Anesthetics used at the usual dose have no effect on peripheral waves. Halogen gases cause minimal changes in subcortical potentials. The latency of cortical potential is increased, thus the subcortical to cortical potential interpeak latency is also increased. Amplitude is reduced. Nitrous oxide, another anesthetic, causes minimal changes in subcortical waves. Latency to cortical wave show no changes, and the amplitude of the cortical potentials are decreased. Propofol produces minimal cortical and subcortical waves changes. So does opioids and benzodiazepine. Muscle relaxants produce no change in latency but allows better wave averaging, thus produce higher amplitude waves. So the answer to this question is D. Next question. Which of the following is not a consequence of increased stimulus rate? A. Increased absolute latencies. B. Decreased amplitude. C. Increased interpeak latencies. D. Decreased reproducibility. One of the most important factors determining latency, amplitude, and morphology of somatosensory evoked potentials is stimulus. The stimulus affects somatosensory evoked potentials through many variables. One of these variables is repetition rate. This frame shows a left median nerve somatosensory evoked potential triggered by a stimulus rate of 5.7 per second. Now I have introduced a second tracing produced by a stimulus at a rate of 31.7 per second. Notice that none of the numbers are multiple of 60. Now I will show you how different parameters are affected by these changes. So absolute latency to all wave will increase with increased stimulation rate. Amplitude of the wave using high repetition rate will decrease. Interpeak latency will remain unchanged. And reproducibility will decrease. Notice in this frame the two superimposed trials at 5.7 stimulus per second. Notice that they are almost interposed perfectly among themselves. Whereas when the stimulus is 31.7, the two trials are rather far apart. So the answer to this question is C. Next question. What is the cause of the P37 to N45 amplitude asymmetry in this study? Please look at the panels below and try to answer the best choice. A. Non-compatible stimulus intensity. B. Different electrode to nerve distance. C. Real but clinical not significant asymmetry. D. Real and clinically significant asymmetry. One of the stimulus factors influencing somatosensory evoked potentials is intensity. Several features are important for the analysis of this study. The stimulus intensity was about the same. The duration of the stimulus was the same. The rate was the same. The amplitude of the popliteal fossa potential was smaller on the left than on the right, and so was P37. P37 amplitude on the left is smaller than on the right. Latency to P37 was normal on both sides, but the distance from the stimulator to the nerve is never known. In this frame, you can see the representation of two somatosensory evoked potentials, one done on the left and one done on the right. The one done on the left has a low amplitude popliteal fossa potential, which coincide with a low amplitude cortical P37 potential on the same side. The one on the right shows a high popliteal fossa potential coinciding with a high amplitude P37 on the same side, as you can see pointed by the arrow. The most likely explanation for the asymmetry found in this study is that the nerve on the side of the smaller potential was further from the stimulator than on the opposite side. So the stimulator and the nerve were closer on the side with a larger, higher amplitude posterior fossa potential and P37 potential. Another less likely possibility is a severe mononeuropathy on the side of the smaller potential. The same rationale that I just explained for the lower extremities also applies for upper extremities. If the distance from the stimulator to the nerve is further on one side than on the other, there would be an asymmetrical potential. But this asymmetry will be present at the level of the posterior fossa potential and also at the level of the P37, and in the case of the upper extremity potentials, we will see the same with the air point potential on the side where the stimulator is further from the nerve, smaller, in association with a smaller N20. So the answer to this question is B. Next question. The stimulus intensity must be the same in both sides to be able to compare latencies and amplitudes. A true, B false. One of the stimulus factors influencing somatosensory evoked potentials is intensity. As you can see in this frame, the left and the right posterior tibial nerve somatosensory evoked potentials were performed using very different stimulus intensity. On the left, 43.9 milliamps were used. On the right, 23.5 milliamps were used. The amplitude of the popliteal fossa potential on the left and on the right is the same. So it is more important for the analysis of somatosensory evoked potential that the potential immediately after the stimulus be the same amplitude than the stimulus be of the same intensity. So the answer to this question is B. Next question. Increasing stimulus duration selectively stimulates motor fibers. A true, B false. Another stimulus factor that influences somatosensory evoked potentials is duration. The usual stimulus duration is 200 microseconds or 0.2 milliseconds. But stimulus with a duration as short as 50 microseconds or as long as 500 microseconds are sometimes used. Motor fibers, probably the alpha motor fibers primarily, appear to be more sensitive to short duration stimulus, whereas long duration stimulus appears to selectively stimulate sensory fibers that go to the muscle and also perhaps those that goes to the skin. So the answer to this question is false. Next question. Which of the following somatosensory evoked potential test is more likely to be abnormal in a brachial plexus lesion selectively involving the upper trunk? A. Median nerve at the wrist. B. Median nerve at the fingers. C. Ulnar nerve at the fingers. D. Ulnar nerve at the wrist. Another stimulus factor that influences somatosensory evoked potentials is location. I am referring to location of the stimulus within the same nerve. Stimulation of the median nerve at the fingers will activate cutaneous sensory fibers, but will not activate muscle fibers. Stimulation of the median nerve at the wrist will activate cutaneous sensory fibers and also muscle sensory and motor fibers. Stimulation of the fingers involving only the cutaneous fibers will travel through the median nerve up to the axilla. At the level of the axilla, the fibers will go to the lateral cord, from the lateral cord to the upper trunk, and then to the ventral rami of C5 and C6 prior crossing the intervertebral foramina and entering in the spinal nerves, the vertebral canal. The course traveled by a stimulus triggered at the wrist because it includes cutaneous fibers from the medial nerve that innervate the ventral hand regions, and also muscle fibers, sensory and motor fibers will involve different structures in the brachial plexus. As previously mentioned, cutaneous fibers travel by the median nerve, lateral cord, upper trunk, and the ventral rami of C5 and C6 before entering the spinal canal in the spinal nerves. But muscle fibers, those are sensory and motor, travel through the medial nerve, then they go to the medial cord, from there to the inferior trunk and the ventral rami of C8 and T1. It is through this rami that they connect with the spinal nerve and enter through the intervertebral foramina towards the spinal canal. So median nerve at the wrist surveys the medial and lateral cords, the upper and lower trunks, and the ventral rami of C5 and C6, C8 and T1. Ulnar nerve can also be checked at the fingers and at the wrist. At the fingers, only cutaneous fibers are stimulated. With wrist stimulation, cutaneous and also muscle fibers are stimulated. But both have the same course. They go from the ulnar nerve to the medial cord, from the medial cord to the inferior trunk, and from the inferior trunk to the ventral rami of C8 and T1 in order to go inside the vertebral canal through the intervertebral foramina in the spinal nerves of C8 and T1. In this frame, you can see the brachial plexus structure involved by the median nerve stimulated at the fingers, the median nerve stimulated at the wrist, and the ulnar nerve stimulated at the fingers and at the wrist. So the answer to this question is B. Next question. Which of the following statements is not true regarding median nerve stimulation at the fingers? A. Absolute latencies are 5 milliseconds more than with median wrist stimulation. B. The lateral cord and upper trunk are activated by it. C. Stimulus intensity should be 2 to 3 times the sensation threshold. D. The usual stimulus is 200 to 300 milliamps. Another stimulus factor that influences somatosensory evoked potentials is the mode of the stimulus. When I refer to mode, I am referring to the type of triggering mechanism used to produce the evoked potential. And this mechanism can be touch, electricity, or laser. Transcutaneous electrical stimulation using rings at the finger is conducted by placing the cathode proximately, preferably at least 2 centimeters from the anode, in adults and older children. In small children, sometimes the distance can only be 1 centimeter. The region selected should belong to the same dermatome, and the intensity should be 2 to 3 times the threshold sensation, which corresponds to about 5 to 30 milliamps. With this method, the air point potential, which usually occurs just before 10 milliseconds after wrist stimulation, occurs at about 12 to 14 seconds after finger stimulation. So the answer to this question is D. Thank you very much for your attention.